Diabetic emergencies, DKA and HHS. The concepts in this chapter are glucose regulation. Interrelated concepts would be nutrition, tissue integrity, sensory perception, immunity, fluid and electrolyte balance, and acid-base balance. Diabetes mellitus is a common, complex, chronic condition in which the ability to produce or utilize the hormone insulin is impaired, resulting in impaired glucose metabolism. Insulin is secreted with food intake to allow the body cells to take up, use, and store carbohydrates, fat, and protein, and this helps keep the glucose levels within the normal range. Proinsulin is secreted by and stored in the beta cells of the islets of Langerhans in the pancreas. It's transformed by the liver into active insulin. Insulin will then attach to receptors on the target cells where it promotes glucose transport into the cells through the cell membrane. Basically, it works as a key. So glucose regulation requires insulin to move glucose into many body tissues. So insulin acting as that key to open up that locked cell membrane to allow glucose to enter the cell. Now remember that glucose is the main fuel for central nervous system, and it requires a continuous supply to prevent neuron dysfunction and cell death. A lack of insulin prevents the body from using glucose for energy. It increases the amount of glucose circulating in the blood vessels, which causes the hyperglycemia when we do that serum blood glucose test. It disturbs fluid and electrolyte balances. It leads to polyuria, polyphagia, and polydipsia. Excess glucose causes an osmotic diuresis that leads to the polyuria, that excessive urination, which then leads to dehydration, which causes the polydipsia or the excessive thirst. And because cells are not receiving glucose, cell starvation occurs, and this triggers polyphagia or excessive hunger, and the client remains in metabolic starvation until insulin is available to move glucose into those cells. Since the body cannot use glucose for energy, it begins to break down fat and protein for energy. Ketone bodies, which are an acidic byproduct of the fat cell breakdown, are released when the body uses fat for energy. This leads to an acid-base imbalance of metabolic acidosis. The increased acid causes the brain to increase the rate and depth of respirations in an attempt to blow off carbon dioxide and acid, called Kussmaul's respirations. Acetone is then exhaled, which causes a fruity odor to the breath, like juicy fruit gum. Dehydration leads to hemoconcentration, hypovolemia, poor tissue perfusion, and hypoxia, which leads to increased lactic acid production, causing more acidosis. The increased fluid loss also causes an excess loss of potassium, leading to hypokalemia. However, in acidosis, potassium ions within the cells are exchanged for hydrogen ions. So with DKA, the client experiences hyperkalemia. Diabetic ketoacidosis is a complication of diabetes that's characterized by uncontrolled hyperglycemia, metabolic acidosis, and increased production of ketones, and is caused by an absence of insulin and the generation of keto acids as the body metabolizes fats instead of glucose to get that energy. Death can occur in up to 10% of these clients, even if we are providing appropriate treatment. Causes of DKA or triggers can be infection, stressors, or inadequate insulin dosage. Symptoms of DKA include those three Ps: polyuria, polydipsia, and polyphagia. Ketosis, Kussmaul respirations, and this is where that body is attempting to correct that acidosis by breathing deeper and more rapidly, the Kussmaul respirations. The fruity odor to the breath from the breakdown of fats for energy. Vomiting and nausea and abdominal pain from the acidosis. Dehydration from the increased diureses due to that increased osmolality of the blood from hyperglycemia. Lethargy, a coma, which are changes in the level of consciousness due to poor tissue perfusion and hypoxia. Shock. Again, the Kussmaul respirations can lead to respiratory alkalosis as it tries to correct that metabolic acidosis by exhaling carbon dioxide, which is an acid. Initially, serum sodium levels might be low or normal. DKA has a sudden onset. With our lab, we're going to see a serum glucose that's over 300. We're going to see serum and urine ketones present, a serum pH that is less than 7.35, a serum bicarbonate level that's less than 15, and BUN and creatinine levels will be elevated due to that dehydration. So what do we do for DKA? Well, we need to manage the blood glucose. We're going to be obtaining blood glucose levels frequently until stable. We need to assess their airway, the level of consciousness, hydration status, electrolytes, and blood glucose levels, monitoring their vital signs every 15 minutes until they're stable, monitoring their urine outputs, their body temperature, their mental status hourly. If there is central venous access, we need to monitor a central venous pressure every 30 minutes. Above all of the above assessments that I just mentioned, and monitoring can be backed off to every 4 hours once the client has stabilized with treatment. We also need to do fluid and electrolyte management. This is restoring the blood volume and maintaining perfusion to those vital organs. So we need to assess fluid and electrolyte balances, the loss of weight, thirst, decreased skin turgor, dry mucous membranes, and elevated urine-specific gravity, weak and rapid pulse, flat neck veins, increased temperature, a decreased central venous pressure, muscle weakness, postural hypotension, and cool, clammy skin can all be seen. We're going to administer IV hypotonic fluid therapy at 15 to 20 mLs per kilo per hour for the first hour, and 4 to 14 mLs per kilo per hour after that initial bolus, up to 6 to 10 liters in the first 24 hours. Once that blood glucose reaches 250 milligrams per deciliter, we'll change the fluid from that hypotonic fluid to a 5% dextrose solution in 1/2 normal saline to prevent hypoglycemia and cerebral edema, which can occur if the serum osmolarity decreases too quickly. It will be important to monitor the cardiac, kidney, and mental status for fluid overload, and monitor blood pressure, I's and O's, and daily weights. Now with drug therapy, of course we're going to administer insulin therapy. We're going to give a continuous regular insulin IV infusion after we give a regular insulin IV bolus. By the way, regular insulin is the only insulin that can be administered intravenously. We need to lower the glucose, lower the glucose slowly, about 50 to 75 milligrams per deciliter per hour. It does require frequent blood glucose monitoring. We may be doing it every 15 or 30 minutes for a while. It just depends on the client and the circumstances. When the client can take oral fluids and ketosis has stopped, then we're going to discontinue the IV insulin and pick up with subcutaneous insulin. DKA is resolved when the blood glucose level is below 200 milligrams per deciliter. The bicarbonate level is higher than 18, and the serum pH is over 7.3. Insulin therapy, correction of acidosis, and volume expansion are all going to decrease serum potassium concentration, correcting the DKA's mild to moderate hyperkalemia. So it's important to monitor the potassium levels. If the serum potassium level falls below 5 milliequivalents per liter, then potassium replacement is done. We also need to assess for signs of hypokalemia, including an EKG. Hypokalemia is a common cause of death in DKA. We may administer bicarbonate if we have severe acidosis, where the arterial pH is 7.0 or lower, or the serum bicarbonate level is less than 5. So different things that we would teach the client on is we need to teach about sick day management. We need to encourage the client to check their blood sugar at least every 2 to 4 hours when the client has anorexia, nausea, vomiting, or blood sugar levels are over 250. We need to encourage them to check urine ketone levels when they're ill, but especially when the glucose levels are over 250. They should be encouraged to drink at least 8 to 12 ounces of fluid every hour while awake, and increasing that amount if infection is present. If nausea is present, we encourage the client to drink liquids that contain glucose and electrolytes. If the client is unable to eat solid foods, then we encourage them to drink fluids that have carbohydrates in it. The client should be encouraged to take a rapid-acting or short-acting insulin or oral anti-diabetic agent based on what their blood glucose levels are. And they should be encouraged to contact the provider if they have persistent nausea, vomiting, diarrhea, and fever longer than 24 hours, their blood glucose is over 250 and does not respond to therapy, they have ketonuria for more than 24 hours, they're unable to take food or fluids, or their illness lasts longer than 1 to 2 days. So now we're going to talk about HHS, or the hyperglycemic hyperosmolar state, sometimes known as hyperglycemic hyperosmolar non-ketotic state. This results from sustained osmotic diuresis leading to hyperglycemia. Usually there is a more gradual onset than with DKA. It can be triggered by infection or other stressors or poor fluid intake. Maybe there's been an MI, sepsis, pancreatitis, stroke, and some medications. There is little to no breakdown of fat in the cells, so there's no ketosis and no ketones in the blood or urine. There is enough insulin to prevent ketosis, but not hyperglycemia. So this means it occurs in your type 2 diabetics. Glucose levels are more often much higher than DKA, and it can cause significantly increased blood osmolarity, which causes extreme diuresis with severe dehydration and electrolyte loss. These clients may also have some confusion to a coma. They may have seizures and reversible paralysis because of that high serum osmolarity over 350. HHS occurs most often in older adults with type 2 diabetes who do not know they have diabetes. Mortality rates are as high as 16%. What do we do for HHS? Well, a lot of it will be very similar to DKA, but there are some differences. The first priority is going to be fluid therapy. We need to increase that blood volume. With shock or severe hypotension, we're going to give normal saline. Otherwise, we will administer 1/2 normal saline. We infuse fluids at 1 liter per hour until the CVP, that central venous pressure, or a pulmonary capillary wedge pressure, begins to rise, or blood pressure and urine output is adequate. Then we reduce the fluid rate to 100 to 200 mLs per hour. Body weight, urine output, kidney function, presence, absence of pulmonary congestion, and jugular vein distension determine the rate of that fluid infusion. We should be assessing hourly for signs of cerebral edema, such as abrupt changes in mental status, abnormal neurological signs, and coma, including pupil size, shape, and reaction, or seizures. Continuing therapy will include IV insulin only after the fluid volume is replaced. The initial IV bolus will be given, followed by a continuous IV insulin infusion. And again, we want to reduce glucose at a rate of 50 to 70 milligrams per deciliter per hour, so slowly. We're also monitoring for hypokalemia, monitoring serum electrolytes every 1 to 2 hours until they stabilize, and monitoring cardiac rhythm continuously. Client teaching will be similar to DKA. It's important to minimize dehydration and prevent ketoacidosis. Case study. We have a 23-year-old client with a history of type 1 diabetes who's admitted to the ED with nausea, abdominal pain, a respiratory rate of 34 per minute, with deep breaths and a fruity smell to his breath. He is responsive but difficult to arouse. What does the nurse suspect is happening with this client? Well, everything is pointing to DKA. What serum glucose level would the nurse expect to see with this client? And per the definition of the DKA, the glucose level is most likely going to be greater than 300 milligrams per deciliter. The student nurse asks why the client is breathing so rapidly and deeply. What is the nurse's best response? His serum pH is high, and this is a compensatory mechanism. His serum pH is low, and this is a compensatory mechanism. His serum potassium is high, and this is a compensatory mechanism. His serum potassium is low, and this is a compensatory mechanism. The correct answer is B. Remember, we're going to have an acidotic state, so the serum pH will be low, and this is how the body tries to compensate by blowing off acid in the form of the carbon dioxide. In the ED, the client is diagnosed with diabetic ketoacidosis. What is the nurse's first priority for managing this condition? Airway assessment, administration of insulin, fluid and electrolyte correction, administration of IV potassium. First priority is airway management, rapidly followed by the administration of the insulin, fluids, and correction of electrolyte imbalances. 20 minutes later, the client is admitted to the ICU for DKA management. The client is receiving IV regular insulin with frequent finger sticks to check his glucose level. Potassium level is 2.5 and IV potassium supplements have been ordered. What assessment must the nurse make before giving IV potassium? Respiratory rate of less than 24 per minute. Production of at least 30 mLs per hour of urine. Level of consciousness and orientation. Finger stick glucose of less than 200 milligrams per deciliter. The correct answer is B. Hypokalemia is a common cause of death in the treatment of DKA, but before giving IV potassium, it's important to make sure the patient produces at least 30 mLs per hour of urine. Two days later, the client has recovered and is preparing for discharge. His wife asks about what they can do to prevent this from happening again. What should the nurse teach the client and his wife? Select all that apply. Monitor glucose whenever the client is ill. Decrease fluid intake when nausea and vomiting occur. Watch for and report any illness lasting more than 1 to 2 days. Check blood glucose levels every 4 to 6 hours if nausea or vomiting is experienced. Check urine ketones when blood glucose is greater than 300 milligrams per deciliter. Correct answers are everything except B. We should not be decreasing fluids. We should be increasing fluids. A nurse is teaching a group of clients about metabolic syndrome, which assessment features are going to be associated with this syndrome. Select all that apply. Male waist circumference of 44 inches. Fasting blood glucose of 66. Triglyceride value of 162. Blood pressure of 135/85. Client is taking blood pressure medication. The only incorrect answer is B. All others are correct. The metabolic syndrome is a simultaneous presence of metabolic factors that are known to increase the risk for developing type 2 diabetes and cardiovascular disease. Features of the syndrome include abdominal obesity, with that waist circumference of 40 inches or more for men and 35 or more for women. Hyperglycemia, which is a fasting blood glucose level of 100 or more, or they're on drug treatment for elevated blood glucose levels. Hypertension, where we have a systolic pressure of 130 or more, or a diastolic pressure of 85 or more, or they're on drug treatment for hypertension. And hyperlipidemia, with a triglyceride level of 150 or more, or they're on drug treatment for elevated triglycerides. High-density lipoprotein, the HDL, or cholesterol level less than 40 for men and less than 50 for women. When caring for a client who has a hypoglycemic episode, the nurse knows which symptom requires immediate intervention: hunger, confusion, headache, tachycardia. Well, we don't have one of our ABCs there. One of the next things we would be looking at would be, we do have a tachycardia, but in this case, we're actually looking at the confusion, which is going to be a change in the level of consciousness. But we also need to consider that glucose is necessary for brain function, and confusion would be a marker of severe hypoglycemia, and that would require immediate intervention. Irritability, anxiety, hunger, tachycardia, headaches, sweating, and seizures are also additional signs of hypoglycemia. The nurse is teaching a client with type 1 diabetes about exercise. The nurse understands the client should avoid exercise during what time? During colder months, when serum glucose is less than 150, when ketones are present in the urine, when emotional stressors are high for the client. The correct answer is C. Exercise should be avoided if ketones are present in the urine, because this indicates that the current insulin levels are not adequate, and exercise is only going to elevate blood glucose levels.